Good afternoon. Welcome to Medical Grand Rounds. I'm Bob Wachter, Chair of the Department of Medicine. Thanks for folks who are here and the folks who are online. Today's topic is redefining mild aortic stenosis. But the topic and the subject is bigger than that. It really is how do we use genetic and phenotypic data to try to look at common clinical syndromes and make better decisions about them and understand the science better than we have. I think this is a time where there's amazing possibilities in this area. And we're lucky to have James Pieruccello, who is a relatively new faculty member here, but I think destined to be a real leader in this area, join us to speak about this. So James is assistant professor in our Division of Cardiology here at UCSF Health. He's also associate editor of the Journal of the American College of Cardiology. His research is focused on what I just talked about, using machine learning and other advanced techniques to enable large-scale phenotyping in areas relevant to human health, particularly cardiovascular disease. I think there's immense potential here, and we're thrilled that he joined us because there are a lot of other collaborators working in similar areas and a lot of opportunity for scaling here. James is from Reno, earned his bachelor's degree in biophysics and biochemistry from Yale, his MD from Hopkins, spent 2 years as a Sarnoff fellow, then completed his medicine residency and cardiology fellowship at Mass General before being recruited here 3 years ago. So James, welcome, and look forward to hearing you talk.
Thank you for the extremely kind introduction and for the opportunity to come talk. I have funding through the NIH, and I have no relevant financial conflicts of interest. I'm going to start with a vignette, and we're going to talk about a 48-year-old man who comes into your clinic because a first-degree family member was given a diagnosis of ascending aortic aneurysm. So he came in to get a screening ultrasound. The ultrasound revealed an ascending aortic diameter of 34 millimeters, which is normal, a normal LV, a normal RV, normal atria, and a tri-leaflet aortic valve with a mean gradient of 10 millimeters of mercury. And my question for you is there anything here that's abnormal? And my hope is that by the end of this discussion, I'll convince you that there is. So aortic stenosis is a pathologic narrowing of the aortic valve orifice. It's an incredibly important disease worldwide, and particularly in the United States. The focus is really calcific aortic stenosis in this talk. I'm not going to dwell on rheumatic disease or bicuspid valve. I think it's probably easiest to sort of address and dismiss severe aortic stenosis up front. If we go back 55 years, Eugene Braunwald has a nice diagram for us of what happens with severe aortic stenosis. There's a pre-symptomatic period, but eventually when you start to develop symptoms, typically angina first, you'll have syncopal episodes, heart failure, and by the time you have symptoms, you're within a sort of 2-year expected lifespan. And there are data that sort of show this. It's not just a diagram. We can go back to the 80s when some of these tilting disc valves were being implanted and look at people who declined intervention and versus people who went forward and had their valve surgery. And the median survival for people who declined intervention was about 1.5 years or 2 years in this group. Obviously, it's confounded, but I think it gives you a flavor for how severe aortic stenosis can be. And the definition of severe aortic stenosis, it's useful to think about it from the sort of hemodynamic parameters that we use to diagnose it. So severe AS, we're looking at aortic valve area less than 1 centimeter squared, a peak velocity greater than or equal to 4 meters per second, and a mean gradient greater than or equal to 40 millimeters of mercury. And so what do you do if you have a patient who has severe aortic stenosis by their echo parameters? Well, we can come back to this UCSF Medicine Grand Rounds from less than a year ago when Dr. Kirsten Tolstrup taught us that you, at the very least, even without even knowing if your patient has symptoms, you've got a class 2A indication to refer to the valve center so that they can help you think about, is there actually some symptom that's lurking that wasn't very obvious, or do provocative testing to elicit symptoms. And so you've already got a class 2A indication even without symptoms. So we are happy to help you. Please feel free to refer these patients to cardiology. Not just feel free, but you really should be getting these patients in to see us. there's a lot more, I think, activity and interest in trying to understand the sort of medical possibilities around mild and moderate aortic stenosis. By the time you're severe, we're going to do surgery. But if you're mild and moderate, maybe we can do something to intervene with medicine. And we would all love to do that. We're all internal medicine doctors. So I sort of think about the data that we have split up into clinical sources of information and research cohorts. So if we start with a clinical cohort, a pretty small 170 people who had mild to moderate disease. And if we look over the course of 6 years of follow-up at the survival of people who have either mild aortic stenosis in that top group or moderate in the bottom group, we see that people with mild disease do better, people with moderate disease do worse. And we can really scale this up. So Beth Israel merged their ECHO database with Medicare claims data, and they're able to show over 10 years of follow-up that the survival of people with no aortic stenosis was the best, mild was a little bit worse, moderate was worse still. And interestingly, in their data, there's no real difference in survival between moderate and severe aortic stenosis. And we can really keep scaling this up. So that was 30,000 people. Let's look at 1 million people. So there's something called the IGNITE database. In this case, they are looking into medical records and just pulling out the text, mild, moderate, severe. So we don't have sort of quantitative valve measurements, but when you look at this large population, we see that over the course of 4 years of follow-up, the mortality going from no aortic stenosis to mild, moderate, severe progresses as the valve severity gets worse. In research data, it's a little bit more challenging to see the consequences of mild disease. So Oxvalve basically took volunteers from clinics who did not have established aortic valve disease, and they asked over the course of 10 years of follow-up, people who on a screening ultrasound had mild aortic stenosis, did they do worse than people with no aortic stenosis? The point estimate certainly suggests yes. The hazard ratio is 1.2 for mortality, but that is not statistically significant. So I think the data are not exactly uniform with respect to the consequences of mild aortic stenosis, but they certainly all point in the same direction, that there are adverse consequences. Certainly does not mean that those consequences are caused by aortic stenosis itself. It could just be a marker of downstream disease, but it absolutely makes us ask the question, is there something that we could do to intervene at these early stages? And so if you're going to intervene, you need to know what the risk factors are so that you can modify them. So let's go way back to the 80s. We're looking almost 40 years ago at a clinical cohort of about 600 people who either did or did not have aortic valve disease. And we see that people with aortic valve disease had higher cholesterol. They were more likely to have hypertension, diabetes, and low HDL cholesterol. Fast forward 10 years, we've got Catherine Otto working with the Cardiovascular Health Study. This is a research cohort, and we see that there are some non-modifiable risk factors. So age is a strong predictor, height. But then there are some that are modifiable. So lipoprotein little a, LDL cholesterol, smoking, high blood pressure. And so when we look at this list, well, you're not going to modify age, you're not going to modify height. Smoking, we already know you should stop. High blood pressure, we already know you should treat. And so you're sort of left with two obvious candidates for intervention, lipoprotein little a and LDL cholesterol. And certainly in 1997, we did not have a lipoprotein little a lowering agent. So everyone's going to think about lowering LDL. And let's march through some of these trials, starting with Saltire in 2005, taking patients with moderate aortic stenosis, randomized to atorvastatin versus placebo. On the left, you just see that over the course of 3 years, atorvastatin works, it lowers your LDL cholesterol. And on the right, you can see that it doesn't do anything to reduce your peak velocity across the aortic valve. In 2008, another pretty small study, 47 people with mild to moderate aortic stenosis, this time treating with atorvastatin 20 and looking at aortic valve calcification as it's quantified. And over the course of 2 years, no difference between statin and placebo. We can keep doing this all day. SEAS in 2008, mild to moderate aortic stenosis, much bigger this time, 1,800 people. And now we're also kicking in not just a statin, but Zetia. And that certainly lowers your LDL cholesterol. No effect on peak velocity across the aortic valve over a little bit more than 2 years. Astronomer, 2010, moderate aortic stenosis, a little bit smaller, Resuva 40, lowers cholesterol, doesn't change peak velocity. I'm just a broken record at this point. Now you get a little bit of something from Fourier, which is the large outcomes trial looking at the PCSK9 inhibitor evolocumab, 27,000 people. But it's important to keep in mind that this is not a trial that is looking at or powered for aortic stenosis. So this is a secondary analysis. The hazard ratio looks great. It's 0.66, but it is not statistically significant. They then play some games where they say, okay, well, after 1 year, that has an even better hazard ratio, and the p-value is significant, 0.03. But that's a secondary analysis of a secondary analysis. So I think the best way to put this right now is that there's no medical therapy for aortic stenosis. And to me, this means that we should try to better understand early stage disease. We're missing something. So how do we sort of get at this? How do we learn the pathophysiology? And my general belief about cardiovascular disease is that whatever drives variation in the population in the quantitative phenotypes, so aortic diameter for aneurysm or aortic valve hemodynamics for aortic stenosis, that will be relevant to the disease itself. To do that, you need to have a large database with a bunch of data. And so I think the best place to look at this type of question right now is the UK Biobank, which is a large 500,000 person prospective study in the UK that enrolled from 2006 to 2010. All the participants were aged 40 to 70 at the time of enrollment. They all have whole genome sequencing. They have lab data, and there are follow-up ICD and procedural codes. They're also doing MRI for no reason. In other words, purely research MRI. There's no indication for these studies in 100,000 people, and they've already completed these studies in 60,000. The image on the right is the flow imaging that we're going to focus on today. The orientation is sort of shown by that mannequin. So it's facing right, and we're actually looking down rather than up for a reason that you'll see in a bit. But the ascending aorta is that circle in the middle of the screen. It's flanked by the atria. So we're just distal, just cranial to the aortic root. And as you can tell, we can't actually see the aortic valve leaflets. We're not at the level of the valve, we're distal to that. So we can't just like planimeter, we can't directly try to trace out the aortic leaflets. But what they have paired on a pixel per pixel basis is a set of velocity encoded images. And so on the right are these velocity encoded images where black is a pixel that is coming into the screen, white is a pixel that is coming out towards you, and how bright it is versus how gray it is measure the intensity or how fast that pixel is moving. And so there's a ton of noise caused by all the air and other non-blood tissue, and it's really important to avoid that noise. Otherwise, it's going to destroy your ability to measure velocities in the fluid. But because these are paired with those anatomical images, we can sort of play a game where we label every single pixel, which is called semantic segmentation, and then we apply that label to the velocity encoded images to extract the data that we actually care about. So this is a collaboration with Shino Canny, who is a talented postdoc in Patrick Eleanor's lab at MGH. And he painstakingly sat there and annotated 1,000 of these still frame images for us. And so then I got to do the fun part of training a deep learning model to do the same task. So for like 5 seconds, this is just like a deep dive into methods, and I will leave it after this slide. But this is a ResNet34 based UNet model. And when we look at a held out test set, the dice score is 0.964. Perfect is 1. So the model is almost perfect, as it should be, because it's literally just trying to trace a circle. This is the easiest task you could possibly ask it for, and it's still imperfect. But it's good enough that we really avoid getting anything outside of the blood pool. And that way we can extract just the data and not the noise from the ascending aorta. So now I'll visualize this differently for you so you don't have to keep staring at a TV screen. We're looking at a cross-sectional plane, but the z-axis here is velocity. And so if we look at someone who has normal velocity across the aortic valve, there's this is someone who has a valve that is wide open. It's not causing any real acceleration across the orifice. And then if we look at someone who has moderate to severe aortic stenosis, there's a pretty high velocity vena contracta in the center. And the point here is really just that this approach, when we look at individual samples to make sure it's working, we think it works pretty well across the range from normal to pretty deranged hemodynamics. And so each person has 30 of these images throughout the cardiac cycle. And that means we can measure velocity at 30 time points. And so here I'm sort of splitting this up into systole and diastole. The x-axis is time. There's just 30 columns. The y-axis is velocity. And the brightness, like how white the pixel is just the intensity. It's how many pixels had that same velocity. So if you get into moderate to severe aortic stenosis, there's a much bigger dispersion in these velocities, again, because there's that vena contracta in the middle with really high velocity data, and then everything else around it is not quite as fast. But this allows us to measure the sort of fundamental hemodynamic parameters that we care about. So we've got peak velocity, gradient, right? Bernoulli simplified is 4v squared. So we can take the gradient at every point in systole and then take the average, the mean gradient. We can compute a modified Gorlin equation for the aortic valve area. So we can get all of these parameters. And this just gives you a flavor for what those spectrograms look like from no disease to mild to moderate to severe. The challenge comes from scaling this up. And I'm not going to dwell on this part actually at all. But what we do in my lab is really engineering. It's making sure that we can go from one observation and then use deep learning at scale in a way where we don't have to go back and manually double check every single thing that we do. So the model has to be good, the readouts have to be correct, and you're not going to be able to look and manually confirm. So that part of the process is the engineering challenge. And I'll just sort of say that that's what we spend a lot of time doing. But the result of this is what you can see here. So these are the histograms for the population distribution in the UK Biobank for 60,000 people looking at aortic valve area, peak velocity, and mean gradient. I think it is particularly noteworthy that men and women perfectly overlap. There's no difference at all for peak velocity and mean gradient. There is a difference for aortic valve area, which I think is driven by different stroke volumes, but the peak velocity and mean gradient are really sex independent. It's useful to confirm that our measurements behave the way you expect. So we look at peak velocity and we can correlate it with markers of atherosclerosis, LDL cholesterol, lipoprotein little a, blood pressure, smoking. All of these correlate in the way that you would expect based on prior studies, which is reassuring. And then I will let you in on a secret, which is the distribution that I was showing you before is really clipping the entire long tail that goes off to the right with high velocity, high mean gradients. And so we should actually look at the full distribution, which is shown here. So there's a lot of derangement from normal hemodynamics. And I can label this for you based on the ACC/AHA guidelines looking at moderate aortic stenosis. And I would like to show you where mild aortic stenosis begins and ends, but I can't actually do that because they only define it as being less than 20 millimeters of mercury. There are some rules around this where they can give you definitions of aortic sclerosis based on leaflet thickening, but mild is like not really well defined. This is true for aortic valve area and mean gradient, and even for peak velocity, where there is a clear definition of mild versus normal, the US guidelines and the European guidelines don't agree. So I think that the mild aortic stenosis definition, this is certainly not something we set out to do, but it looks like a little bit of a mess. So we thought maybe we could offer a stab at solving this issue. And then if we like pull up, how did those studies that I showed you define mild aortic stenosis? No two of them really defined it the same way. So we're not comparing apples to apples in any of the data that we've looked at so far. So I think that there's two problems. There's basically lack of agreement on where we should draw this boundary and irregular use of valve area and mean gradient in defining mild aortic stenosis. So we took a healthy subset of participants. Anyone who had aortic stenosis or coronary disease, heart failure, or even hypertension was excluded. We then, for men and for women separately, grouped people into 10-year groups and looked at the values that were above the 95th percentile for every single person in all of the groups, giving us our abnormal high and abnormal low definitions, which I think are better visualized in this plot. So red is severe, orange is moderate, and then blue is our proposed mild aortic stenosis threshold. And I think just visually, it calls your attention to the fact that what is left in the normal range really sort of fits into what you would classically think of as a normal distribution. Valve area at the bottom looks a little bit messy. This is again because men and women have different values, and so I'm simplifying in this plot. So we can then propose that we take this sort of lack of clarity between mild and normal and define it very clearly. And so what we'll do is now explore some of those phenotypes based on our definition to understand what does this teach us. If we actually apply this, how does that look? The first question is like, what fraction of the population are we now assigning to a disease state? Because before they were just normal. So the disease state is really just 5.8% of the population. And again, this is people who were at least 40 years old at the time of enrollment. So we're left with 93.5% of the population that is still in the no disease category. If we follow folks for 5 years after their MRI and ask how many of them go on to have aortic valve surgery or TAVR, first of all, in the severe group, something like 60% do. And I think that's reassuring. If our measurements, which we did in an automated fashion, and without really manually inspecting any of them, didn't show that severe aortic stenosis was getting aortic valve surgery, we'd be doing something incredibly wrong. So this is sort of like a gut check, making sure it's right. And then if we compare mild to normal, over the course of 5 years, about 2% of the mild group goes on to become severe and require aortic valve surgery. But I think equally important is that there's no residual risk in that no group over 5 years. Obviously, over time, that will not be true, but in a 5-year window, this is essentially a guarantee that you're not going to require aortic valve surgery. In the paper, we sort of show this simplified set of consequences of mild aortic stenosis compared to people with no aortic stenosis. So these folks are at higher risk for VT or cardiac arrest. Now, this is notoriously hard to define through ICD codes and procedural codes, so I think take that with a grain of salt. But certainly heart failure, atrial fibrillation, and mortality is increased in the mild aortic stenosis group compared to the remainder. And keep in mind, in Oxvalve, they were not able to show that. So here we can sort of confirm that it is statistically significant. For this group, and I guess the entire internet, I'll unpack this a little bit in a slightly larger sample size from what we published. And we can really see that the hazard ratio for mild aortic stenosis compared to normal is pretty noteworthy for people who undergo ICD implantation or who have cardiac arrest. I sort of summarize this as there's atrial and ventricular arrhythmia, there's heart failure, coronary disease, diabetes, hypertension. Very clearly, some of these are not caused by aortic stenosis. Diabetes is not caused by mild aortic stenosis. So some of this is also just recognition of things that must have already been present at the time of imaging. But others, like the arrhythmias and heart failure, I think are candidates for at least being related to mild aortic stenosis. And trying to unpack that mortality risk, because again, it doesn't have to be even cardiovascular. This could just be a sign of cancer for all we know. But if we look at the death certificates, which are centrally adjudicated in UK Biobank, we see people where their death was attributed to aortic stenosis, that the hazard ratio of mild versus normal is almost 30, or primarily attributed to cardiovascular death, it's over 2. And then in all-cause mortality, as we already talked about, and then getting down into non-cardiovascular death, so cancer death, respiratory death, there's no relationship. So I do think that this at least hints at the idea that that risk from mild aortic stenosis is cardiovascular specific, and some of it is actually happening through the valve itself. So this is all MRI. Nobody uses MRI for valve disease, more or less. The workhorse is really echocardiography. And so we wanted to make sure that if we applied our thresholds in echo data, that it would actually be relevant. So we collaborated with the National Echo Database of Australia, where they took 350,000 people, applied our mild aortic stenosis definition, and then tested the only outcome that they have currently. They're working on this, but mortality is the only available outcome. But we do see over 18 years of follow-up, compared to people who have no aortic stenosis in that black line at the top, people who have mild disease do a little bit worse, moderate worse, severe even worse. And mild really sits right in between normal and moderate. So I think it gives us confidence that if we apply these thresholds to echo data, it's going to behave in a way that we expect. So this work was just published 2 weeks ago to the day. So you can see a whole bunch of what I just talked about in that paper if you want something to cite. And this is why when we come back to that vignette and ask, is there any abnormality on this echo? I think that the answer should be yes. I think that 10 millimeters of mercury gradient across the aortic valve is actually kind of square in the middle of what we should think of as mild aortic stenosis. And if we eventually decide to change our guidelines and say that this is mild aortic stenosis, does this matter? I also think the answer is yes, because when you leave normal and enter mild aortic stenosis, you exit stage A and you enter stage B. And so at the very least, for stage B, we start thinking that you should get an ultrasound every 3 to 5 years. But I think it also starts to qualify you for clinical trials. There are other things that we can be doing when we identify people who have at least mild aortic stenosis. So where are we? We've measured aortic valve hemodynamics in a whole bunch of people. We've sort of confirmed that it's associated in the ways that we expect. And I've also walked you through a bunch of clinical trials showing that LDL lowering is not effective. So I think the question that we could be asking is, have those trials all been applied at a stage that's too late to really make a difference? Going back to that mild aortic stenosis definition, whether you're using the European or American guidelines, you're already well along that tail, way outside the normal distribution. And even if you use our guidelines or our proposed mild aortic stenosis definition, I think the same is true. And that is a little bit of a challenge, because does that mean you have to intervene on people who have normal aortic valve function? And if so, how do you find them? Or maybe we're just looking at the wrong targets. So what do I mean by that? Well, let's use genetics to help us think about what the right targets could be. One possibility is that LDL helps you find people with aortic stenosis, but it's not actually related to aortic stenosis itself. So it causes heart attack. People with heart attack get echo. So great, you find someone who has aortic stenosis because their LDL was high, but that wasn't the reason at all. That's one possibility. Or another possibility, we know that lipoprotein(a) is also strongly associated with aortic stenosis. So maybe LDL is just correlated with lipoprotein(a), and actually lipoprotein(a) is the only causal molecule here. So these are the sort of things, even within just cholesterol, that we can start thinking about. So if we call back to Rick Lifton's talk, we can sort of think about rare genetic variants, common genetic variants, starting with the rare stuff, which I think is really easy to reason about because it has a huge effect size, typically looked at in family studies, but the biobanks are big enough now that you can actually look in large populations without having to structure a family pedigree. And so Shino did this analysis where we took everyone in the UK biobank with an LDL receptor loss of function variant, which means that they're not pulling down ApoB containing particles, which means that their circulating LDL is too high. So these are people who are going to have really high LDL. And we then looked in those 60,000 people whose MRIs we've measured and asked, is there a relationship between the LDL receptor loss of function variants and peak velocity? And the answer is yes. These people tend to have higher peak velocity, and same deal with PCSK9. So if you lose PCSK9, you have lower LDL cholesterol, and those people tend to have lower peak velocities. And then Yoel Ramo, who is now a medicine resident at the Brigham, has access to FinGen. And so he performed this analysis there, looking at LDL receptor loss of function variants and aortic stenosis diagnoses. So the x-axis here is the effect that those LDL receptor variants have on LDL cholesterol. And the y-axis is the odds ratio for aortic stenosis. So basically higher LDL driven by LDL receptor loss of function variation, higher risk for aortic stenosis. And it's very clear if you look in these same participants that the LDL receptor loss of function has no effect on lipoprotein(a) concentration. This has actually been debated a little bit in the literature, so I just sort of checked before giving this talk, but there's 2.5 standard deviation increase in LDL, which is sort of like an 80 milligram per deciliter increase if you account for people who are already taking statins. And then there's no change in lipoprotein(a). So we'll say, I think from the rare genetic variation in in LDL receptor loss of function variation, we see an increase in peak velocity, even in people who don't have disease, right? This is just a population analysis. So higher peak velocity, higher risk for aortic stenosis, and it's definitely not working through lipoprotein(a). So I think very good evidence still supports the LDL hypothesis. The question is still when. And then let's also look at the other side of the allele frequency spectrum, so common genetic variants that we all have, but they typically have a tiny effect size. So the purpose of this is not to say these variants are going to tell us who's going to get aortic stenosis. The purpose of this is to identify regions of the genome that may have targets that we can then use as we start to think about, can we develop new drugs? When we perform this test, so this is a genome-wide association study, and all that really means is that each genetic variant, we're conducting linear regression with our aortic valve measurement as the output, or as the dependent variable, and your genetic variation as the independent variable. When we do that for tens of millions of genetic variants, we find 54 different regions of the genome that are associated with variation in these valve hemodynamic measurements. I will just focus on two here. One is the fatty acid desaturase locus, which is involved in LDL biology, and the other is lipoprotein(a) itself. Now, this doesn't tell you the direction necessarily, it just tells you that this region of the genome is important. We can use other tools, such as Mendelian randomization, to try to get more information about directionality. So I will not get into the sort of intellectual basis for Mendelian randomization, but I will briefly say that putting it into practice is taking independent genetic variants for your exposure, in this case, lipoprotein(a), and then looking up the same values for the same SNPs in your outcome, in this case, peak velocity. And so we are trying to genetically mimic what would happen if we injected some lipoprotein(a). And we see that the higher the genetic dosage of lipoprotein(a), the greater is the expected peak velocity, which supports what we see observationally. So we expect lipoprotein(a) is a risk factor for aortic stenosis in greater velocities across the valve. We can do the same thing with ApoB, which is the main protein particle in LDL cholesterol. Greater genetically mediated ApoB leads to higher velocities across the valve. And it's not just a false positive generator. If we look at HDL, which in that very early study that we looked at was inversely associated with aortic stenosis risk, we actually can build an instrument that explains 15% of the variability in HDL, which is like 30% of the heritable component of HDL. So these 300 variants are a very powerful predictor of HDL, and they have no association with peak velocity. P-value is 0.5. So I think it supports causality for LDL and lipoprotein(a) and really not for HDL. We can bring all this genetic data together, looking at the hemodynamics and aortic stenosis as a disease in a principled way with something called multi-trait meta-analysis. And if we do that, we get up to 162 different parts of the genome that are associated with aortic valve either function or aortic stenosis as a disease. I'm really just going to highlight that cholesterol biology keeps coming up over and over and over again. So 10 genetic loci, not just lipoprotein(a), but like the LDL receptor, PCSK9, ApoE, and a whole bunch of others. these are all associated at genome-wide significance with aortic stenosis. So there's something here that keeps reminding us that there's a relationship between cholesterol and aortic stenosis, even though our trials have not been successful. I will talk about one thing that's not cholesterol, just so you're not like sick of me talking about cholesterol. This is FGF23, which encodes fibroblast growth factor 23. The variant itself is actually a missense variant that has a consequence on the gene. And the gene in the protein product modulates renal phosphate absorption. And so we said, okay, let's look at phosphate. What does that look like in a Mendelian randomization? And sure enough, higher genetically mediated phosphate is associated with greater risk for aortic stenosis and a narrower aortic valve area. So I think that there may be something that's worth considering. And certainly there have been small trials, particularly in people with advanced renal disease, looking at phosphate lowering. But this raises the question, or I think it should, of whether this may be something that's worth considering in a larger trial. The other thing that people like to do with genetic data is to produce polygenic scores. So we can do the same thing. We basically take a set of UK Biobank participants who were not in the genome-wide association studies. We build these polygenic scores for millions of genetic variants. We apply them to each person, sum them up. Each person then has a score. That score is sort of like your LDL cholesterol, but in this case, it's your genetic risk for aortic stenosis. And if we follow those people up for almost 15 years, we see that there's a big gap in the risk for aortic stenosis as a diagnosis for those who are in the top 10% compared to the middle 80%. And same, the bottom 10% have a much lower risk. So we can sort of stratify people into high and low risk based on this polygenic score. And I actually think the more interesting part of the score is not necessarily that it helps us identify people at higher risk for aortic stenosis, but it's sort of that if we apply this to coronary disease, which I think a lot of people think of calcific aortic stenosis as like atherosclerosis of the aortic valve, they're not really the same. This score does not help you identify people at high risk for coronary disease. And so to me, this is an important observation because as we go through the conclusions, first step is really we propose a definition of mild aortic stenosis, and we see genetic data that really supports LDL and lipoprotein(a) as causal in the pathogenesis of aortic stenosis. But the issue with timing is that it may have to be primordial. It might have to be that we're identifying people in that normal distribution before they even get mild aortic stenosis. And so if we think about that polygenic score, well, first of all, it tells us that the ASCVD risk scores may not be the right scores for identifying aortic stenosis risk. And two, it tells us that we probably need a specific aortic stenosis score, which is going to be genetic and phenotypic to identify people at highest risk, most likely to benefit beyond the current ACC/AHA guidelines for cholesterol lowering. And then, of course, I think the most important part that you can take from the genetics is that there are other potential therapeutic targets. We sort of looked at one of the obvious ones in phosphate, but there are many others that I hope will be useful as people look for drug targets. From an educational standpoint, I just want to emphasize that there's still no medical therapies that have been shown to reduce either the development or the progression once it starts of aortic stenosis. And we do know, whether you're using our definition or others, that mild aortic stenosis does identify people at higher risk for heart failure, AFib, and early mortality. And if you identify a patient that you're taking care of who has mild aortic stenosis, just keep in mind that you should be getting imaging every 3 to 5 years for the ACC/AHA guidelines. And reemphasizing, the proposed mild aortic stenosis thresholds are new research findings. They are peer reviewed. It is published, but these are not in the clinical guidelines. So I don't want to suggest that people use them to guide their clinical practice. And I do expect that because ECHO is the clinical workhorse, we're going to need to refine these so that they make sense with ECHO data. And with that, I will stop. I want to say thanks to the UK Biobank participants, to Patrick Eleanor at MGH, to Shino at the Broad, Yoel at FinGen. And then I want to highlight Sammy, who is the only author that is actually on a valve team anywhere. So Sammy is on the valve team here at UCSF. Leeds Interventional Cardiology. That is the URL for the valve clinic. And so, please get in touch with the valve clinic if you have patients with aortic stenosis. And with that, I will say thanks.
Thanks, James. That was terrific. With plenty of time. So let me start out with a few. If I get an echo here today, will it tell me that I have mild, or it has not reached our own echo department? Yeah. Actually, you can stay there. I'll do them.
Depends on the reader, depends on the day, depends on the severity. So some people are routinely reading out not just the sort of severity, but also the quantitative measures. Not everybody. And particularly the more normal your echo is, the less likely it is that someone's going to specifically quantify these measurements.
So it's not standard of care at this point.
That's right. Yeah.
If I can't think of another entity where high cholesterol is associated with bad stuff and you treat the high cholesterol and it doesn't get better. So one hypothesis is we're too late. And that's one sounds like you're partly running with. Are there hypotheses why it wouldn't work? Why lowering the cholesterol wouldn't work?
Yeah, or so maybe I'll elaborate first on like what does it mean to be too late, and then we could talk about other possibilities. So I think they almost point in the same direction, but if the way that you get aortic stenosis, or if one way that you get there is you have some deposition of ApoB containing particles, and it does behave like early atherosclerosis where you get macrophages that invade and you actually get a little bit of foam cell formation. If all that takes is for inflammation to start, then once that inflammation has started, additional ApoB deposition may or may not matter. So that is one possible reason why catching this after there's some stenosis may just be too late. And so I guess the other piece of why might LDL lowering not be effective is if you think about statins as anti-inflammatories, which I don't, I think this might be particularly confusing. You might really expect, even if the inflammation hypothesis is the driving answer for why are we too late, well, shouldn't LDL lowering help you there because it's a statin and it reduces inflammation? I just think that it doesn't actually reduce inflammation. So that would be my other piece of the same answer, maybe.
Okay. You've convinced me that if I have this mild aortic stenosis, I'm more likely to have bad stuff. You've also convinced me there's nothing I can really do about that. And I guess what I'm not sure about is what's the value of screening, or am I destined, if it's going to get worse, to have symptoms and then I can get tested and treated at that point?
Yeah, I think that's a very good question. So I think the value of follow-up is that some people have accelerated progression to severe aortic stenosis. And so what we would like to do is identify those people before they're symptomatic. Because if someone already has LV dysfunction or another indicator that they're hemodynamically compromised, even though they're not symptomatic, then that's an indication for us to at least discuss valve replacement. But I agree that upfront screening, so the reason my vignette was someone was screened for a different purpose is because there's not necessarily a reason to screen all comers with echocardiography. So this is still in the realm of someone happened to be discovered to have mild aortic stenosis. And I agree, there's not, in the absence of therapies that are going to let you do something, this is really in the realm of, again, identifying people who become high risk quickly, and also maybe thinking about who is going to qualify for clinical trials, which I may have already made you pessimistic on, depending on what you think the clinical trial is going to be doing and what stage we're going to intervene on.
Yeah. I guess one more question about screening, which is I know that other people working on AI and machine learning kind of stuff are finding that you can pick out diseases, I think, like aortic stenosis on an EKG. And that would at least potentially open up a new either opportunity or can of worms as we define these people either having aortic stenosis or at risk for aortic stenosis early. Can you talk about that and then how that would play out? Now you're not doing an echo on everybody, but maybe you're doing an EKG on everybody, and that puts people into this category and you have to figure out what to do with that.
Yeah, absolutely. I think that's a very exciting area. It's something that we're doing, both of these quantitative hemodynamic measurements something that Pierre Elias and like the group at Columbia have published a lot on. He and I actually collaborate. He's shared his model weights. I've run them against these measurements. They don't seem to work very well, but he and I are still working on that. Sorry, Pierre. So I do think, I guess the way that I think about identifying at-risk people is that what you're really looking for is information. And so there's information in the genetics, there's information in the EKG, and those are pretty cheap if you amortize them across all the diseases that you can gain information about. So I do think that those will be useful, and that we may well say everyone should have a genome once and an EKG every so often. Let's think about proteomics. I mean, an Olink 3000 panel is like $500, not CLIA, but you can really start to think about that cost across all the different diseases we're at risk for. Could we do this in a principled way that allows us to identify these people in that normal distribution, not out on the tail, and figure out who needs to be screened and who would benefit from early treatment?
Right. I'll ask one more question, then open it up. This is for the non-biophysics majors among us. Always felt like velocity is interesting, but doesn't it get to a point where the thing is so stenose that your velocity goes down, or is that wacky?
So that is a real problem, especially you're going to start thinking about like low flow, low gradient. So like if the LV is facing super high pressure, you're going to start becoming dysfunctional. And because this is UK Biobank, it's a healthy group of volunteers. If you're sick, you're less likely to actually say yes when they call you back and say like, hey, do you want to sit in another MRI? So there is definitely a healthy volunteer bias that in some sense protects us a little bit from that. But I think the next step for us is looking into people who do have a little bit reduced stroke volume, understanding what is the function of their LV, and could we be missing some low flow, low gradient severe AS, or even more fun, the paradoxical low flow, low gradient, where everything else looks preserved, the ejection fraction is normal, but they have low stroke volume. So there are pieces of this that I think would benefit from being refined, but certainly the answer to your question becomes yes, because of derangement of LV physiology.
Got it. Great, thank you. Let's open it up to others. You could say who you are.
Hi, I'm Francesca Delling from cardiology, and I'm actually part of the valve team. So I see patients also with aortic stenosis in clinic, and I'm an echo reader. So great talk. I have two questions. So one is related to increased mortality in mild AS. And I'm having a little bit of a hard time kind of believing this with the whole kind of LDL and elevated cholesterol that goes with that. So I was wondering about adjustment for LDL values, statins, or because you mentioned an adjusted analysis, but I wasn't sure what you adjusted for.
Yeah, great question. So the analysis is adjusted for age, sex, height, weight. It is not adjusted for cholesterol. It's not adjusted for statin usage. The cholesterol is tricky because the cholesterol measurements come from like 12 years on average before the MRI. And so you run into this, if you're adjusting for older LDL, we still expect that it's more useful than nothing. But that's the reason we didn't include it in these models. I don't know off the top of my head how this looks after you account for LDL.
Are you confident that it's not a confounder, that it's not just?
Could certainly be a confounder. Yeah, absolutely. The reason that I think the genetic evidence is the better evidence for saying that there's causation here. And then also in terms of why do we think that a mild aortic stenosis is on the pathway to mortality, I do think that the effect estimates for like aortic stenosis specific mortality, cardiovascular mortality, and then no relationship with cancer mortality, I think those point us in this direction, but none of that is conclusive. And there's really, I think we need longer follow-up to actually be able to account for all the different risk factors that we already understand to be confident that this is driving the outcome.
It's not a surrogate of high cholesterol values, basically.
Yeah.
Mild AS, right? And that elevated cholesterol is the driver of higher mortality. That's what I think is still unclear.
It's certainly possible. I think the only issue is, even in the genetic data, if you look at the effect estimates, like to me, it's like, is it causal or not? So I'm excited about the fact that it looks causal, that LDL looks causal for greater risk for aortic stenosis. But the attributable proportion is going to be low. Like these effect estimates are pretty tiny. So I would actually be very surprised if LDL was a confounder to that degree. It is definitely possible, but I would be quite surprised. I'd be very pleasantly surprised because we can actually fix that problem, but I'd be surprised.
I have another question. Yeah. So as an echo reader, I have to say, I tend to report mild AS when I see a valve that's a little bit calcified. So the visual factor is very important. So I was wondering if you're thinking about kind of looking at calcification of the valve as an additional parameter to assess for stenosis. Because that's what we do for low grade and low AS, that we do CT and we measure the amount of calcium. So is this something that you could do like in a cohort with CT or?
Yeah, it's a great question. And I certainly agree that I think the way that gets read clinically is different. With this imaging, we can't do it because we don't see the valve. And our goal was basically to say, if we were purely hemodynamic, what does that look like? Because otherwise you're sort of getting into like the sclerotic component. And I don't know, because again, I don't have this in the same people. And I think this is kind of the question you're getting at also is, if we look at the hemodynamic consequences and also that sort of thickening athero type consequence, are these purely redundant with each other? Or is there information in the hemodynamic component that's independent of some of that leaflet thickening? So I think, like you're saying, I mean, we could do this in UCSF data for people who have CT and echo. Like, I think that's the type of question that we can answer clinically. I don't think that the answer to that is well known.
Great. Yeah, just a couple questions from the chat. So one was, what can you tell us about the risk of mild AS in the end-stage renal disease population?
Personally, I can't tell you much.
The question was, have your studies evaluated the risk of mild AS? And if not, I guess any opinions you may have about the topic.
Yeah, so we should collaborate. The number of people with end-stage renal disease in UK Biobank is pretty low. And so then if you cross that with the number of people who have MRI, you're looking at a vanishingly small population. There is signal for a relationship, but so it does look like advanced renal disease is a risk factor. Based on what I showed you, I'd sort of guess that that's probably driven by the phosphate levels. But I really have no data that I could defend in a publication to support that.
Great. Next question is that the writer appreciates that you excluded bicuspid valves from your talk because it has a distinct biology that may include the aorta, but sort of a frequent congenital entity, longer time course involved. And so this person is wondering whether there are data or trials that might favor a more aggressive approach to lowering LDL in bicuspid.
There is. I actually took it out of the talk, but one of the trials did look at LDL lowering in bicuspid. These are all small. So the effect size of statins would have to be enormous to show any effect. But people have tried, it hasn't showed any benefit, but I don't think that is a definitive negative result. I think that question is really interesting because, these people have higher risk for progressing to severe aortic stenosis. And the question is like, could we treat it in some sense like calcific disease, just like as an accelerated calcific disease? That's at least what I would be thinking for why were we lowering LDL cholesterol in people with bicuspid valve disease. So I like that idea, but I don't think it's been successfully shown.
Can I ask one more from the audience? So anything in the pathophys of stenotic aortic valves that supports the role of lipids, like lipid inspisation? Is there anything in the pathology of stenotic aortic valves that supports the role of lipids, like lipid inspisation?
I think Catherine Otto has some nice work from the 90s, actually looking at the contents of the aortic valve. But it's not really my area of expertise. Dr. Delling may have deeper thoughts on this.
I was going to ask maybe a parallel question, which is what would be the pathophysiology of arrhythmias in people with such mild disease. And I don't know if there have been studies of autopsies after people died of car accidents where they had relatively mild disease, but there's something infiltrating the myocardium, or is it stretch or what?
Yeah, so I think if it's true, and there's a very good chance it's not, but if it's true and if it's actually driven by the valve, then the way that you get there is probably driven by increased LV, like wall stress, fibrosis, and something along that type of pathway. We're sort of equipped to answer this a little bit because these people have T1 mapping, but it's just at one cross-sectional level. But it is a question that I think a lot of people are interested in because if it's truly driven by the resistance, again, it's not a huge resistance, but it's sort of like adding 10 millimeters of mercury to your blood pressure every day, every waking moment. Like maybe that's enough for some people to tip them into it. If this is wrong, if this is like a red herring, then the way you get there is probably just coronary disease.
Got it. Any final questions? Great. James, thank you so much. That was great.